that is a very famous hospital for all the traumas and spine surgery. Particularly, it's one of the leading center who does the spine surgery in the world. Of course, it is maybe in top 10 centers in the whole world doing spine surgeries. We are privileged to have a consultant from Ganga Hospital and a postgraduate who will discuss about anesthesia for scoliosis surgery. We'll have a discussion with myself and Dr. Senthil Kumar. Before going for anesthesia for scoliosis surgery, we'll have a lecture on Costo-Clavicular Block. There is a new segment where it has replaced so many things, and we'll have an idea after Dr. Senthil Kumar discuss about it. Yes, sir, we can go ahead.
Good evening, everyone. Thanks a lot, Dr. Vijay Kumar sir, for this initiative. Doing a great job, and thanks for giving us opportunity today. Good evening, everyone. Today, I'm going to talk about Costo-Clavicular Block. A short talk of 10 minutes before the case presentation is going to happen, because every one of you should know about this Costo-Clavicular Block, and you should have performed at least 10 blocks before you finish your post-graduation. It's otherwise called the spinal of upper limb. Regards from Ganga Hospital. I'm going to speak on these topics: brachial plexus anatomy, the line of Grossi, infraclavicular area, medial infraclavicular area or costo-clavicular space, and the block per se. Just a recap of the anatomy of the brachial plexus. The brachial plexus is formed from the anterior primary rami of 5 roots: C5, C6, C7, C8, and T1. The two roots, the upper two roots, C5 and C6, join to form the upper trunk. C5 continues as middle trunk. C8, T1 continues as join to form the lower trunk. From the individual trunks, you get the divisions, anterior and posterior divisions. The anterior division of upper and middle trunk join to form the lateral cord. The anterior division of the lower trunk forms the medial cord, and the posterior divisions of all these things form the posterior cord. From that, you get the final 5 branches: musculocutaneous nerve, axillary nerve, radial nerve, median nerve, and the ulnar nerve. This is the basic anatomy of your brachial plexus. And what is called the line of Grossi? When you connect the 4 markings, first marking is the apex of the scalene triangle at the level of C5, the midpoint of the clavicle, the third point is the deltopectoral groove, and the fourth point is the pulsation of the axillary artery. When you connect all these points, you get a straight line. The plexus can be blocked anywhere along the straight line. That's called the anesthetic line of brachial plexus or line of Grossi. Anywhere along this line, you can block the brachial plexus and get anesthesia the upper limb. Okay. One of the main complications of brachial plexus block, particularly above clavicle block, is the hemidiaphragmatic palsy and the respiratory distress following that. With interscalene block, you get about 60 to 100% of the hemidiaphragmatic palsy. Usually with landmark technique or peripheral nerve stimulating technique, we get about 90% of the blocking hemidiaphragmatic palsy. When you bring down the volume to 5 to 10 ml, the incidence of diaphragmatic palsy can be reduced to 10 to 20%. Still, there is a chance. With supraclavicular block, there's a chance of 40% of getting hemidiaphragmatic palsy and patient landing up in respiratory distress. While in case of an infraclavicular blocks, it's very minimal. The chances of hemidiaphragmatic palsy is very minimal. That's why today I'm going to speak about the costo-clavicular block and its importance. Today I'm going to mainly focus upon the infraclavicular area. The infraclavicular area can be divided into medial infraclavicular fossa and the lateral infraclavicular fossa. These are the two things. Just below the clavicle comes the medial infraclavicular fossa, and furthermore infralaterally, that is the lateral infraclavicular fossa. What is a costo-clavicular block? It is otherwise called the spinal of upper limb. Previously, the supraclavicular block was called as spinal of upper limb, but once the introduction of costo-clavicular block, it is called the spinal of the upper limb. It is this man, Professor Manoj Kumar Karmakar, who introduced this block in the year 2015. He published a paper in the RAPM journal, that is the index journal for nerve blocks in the year 2015. By that time itself, he had done more than 100 cases and he published an article regarding the Costo-Clavicular Block. What is the costo-clavicular space? It is otherwise called the medial infraclavicular space. As the name suggests, it lies between the clavicle above and the second rib below. Costo and clavicle. The costo is the rib. Okay. It is the space formed by the anteriorly by the pectoralis major and subclavius and inferiorly by the serratus anterior below that. This is the space occupied in between the two muscles, the subclavius and the serratus anterior. What are the constituents of a costo-clavicular space? We have the axillary vein medially, first part of the axillary artery, and the cords of the brachial plexus lying lateral to the first part of the axillary artery. What is the difference between the costo-clavicular block and the classical infraclavicular block? Nowadays, it is called the lateral infraclavicular block. What is the difference? Why the costo-clavicular block is given more importance than the classical infraclavicular block? Here you can see in the picture, here the cords are grouped together in the costo-clavicular space lateral to the first part of the axillary artery. In comparison, the classical infraclavicular block or the lateral infraclavicular block, the cords are distributed around the second part of the axillary artery. In costo-clavicular block, because they are grouped together, it will be easy when you visualize in the Sona anatomy. But in case of a lateral infraclavicular block, we can't visualize all the cords in a single Sona anatomical view. We need to do some minor adjustments. And the costo-clavicular block, the cords are placed more superficially. But in case of infraclavicular block, they are placed much deeper into the pectoral muscles, about 4 to 5 centimeters. These are the basic major differences between the costo-clavicular block and the lateral infraclavicular block. What are the advantages of a costo-clavicular block? Due to its compact arrangement, you get a rapid and dense blockade of the upper limb. That's why it is called the spinal of the upper limb. The cords are situated more superficially. There is low incidence of hemidiaphragmatic palsy is least or very minimal, about 5%, 0 to 5%. The incidence of pleural puncture and pneumothorax is very minimal. It's more promising for shoulder surgeries. It is an ideal for high-risk patients like pulmonary dysfunction or obese. It's also more favorable for placing continuous catheters. What are the indications of costo-clavicular block? Any surgery over the upper limb, right from the proximal humerus, midarm, elbow, forearm, and the hand. Any surgery over the upper limb can be done under costo-clavicular block. How do you position the patient and how do you place the transducer and ultrasound machine? Ideally, the patient should be placed in supine position, head to turn towards the opposite side. The ipsilateral arm should be abducted, and then the operator should stand at the head end of the patient. And ideally, we require a high frequency linear probe. As it is a superficial structure, high frequency linear probe will be enough, and the ultrasound machine, the screen should be at the opposite side. And once how are you going to place? Place your probe just immediately below the midpoint of the clavicle, medial to the coracoid process, in a transverse oblique orientation. Your ultrasound probe should be placed parallel to the clavicle, just below the clavicle in a transverse oblique orientation. What do you see? You will see the pectoral skin, subcutaneous tissue, pectoralis major muscle above. Beneath that is the subclavius muscle. Beneath that you get a neurovascular structures. You switch on the color Doppler, you find two structures. One is the artery, another is the vein. How are you going to differentiate? The vein is compressible and it is more medially located. The artery is not compressible. And you can see the neural structures, the cords of the brachial plexus, much more lateral to the first part of the axillary artery. Serratus anterior muscle, inferior to that, and pleura much more beneath that. This diagram shows you the arrangement of the muscles and the neurovascular bundles in the costo-clavicular space. The pectoralis major muscle above, the subclavius muscle below, and the neurovascular axillary vein medially, artery in between the nerve and the vein, and the cords of the brachial plexus are arranged lateral to the first part of the axillary artery. Once you place the linear high frequency probe in the costo-clavicular space, you don't get the typical picture of this, but you can get many views with the different veins coming into the cephalic vein, draining into the axillary vein, thoracoacromial artery, and then clavicle as such, or many things. There are 5 steps how you can get a best possible image when you place the probe in the costo-clavicular place. Let's see one and above. This is a short video to show you when you place how to get a correct orientation in the costo-clavicular space. The first thing is that you place a probe on the clavicle and then slightly slide the probe inferiorly. You see the axillary artery, vein, and the cords lateral to that. You can also see the cephalic vein draining into the axillary vein, cephalic vein draining into the axillary vein. Let's see one by one. First, place your probe over the clavicle. You get a hyperechoic line and a shadow beneath that. Next, you see the cords. When you slide the probe slightly infralaterally, you see this view of cephalic vein draining into the axillary vein. This means that you are little more infralaterally. So you have to go little more cephalate and then tilt your probe towards the head end. One of the next view is the appearance of the thoracoacromial artery. This is seen furthermore, little more infralaterally. If you get this view, you have to move little more cranially. Next is the classical infraclavicular view, sonoanatomy of the view. Here you can see the second part of the axillary artery and the vein. Here from superficial to the deep, pectoralis major, pectoralis minor, and the second part of the axillary artery and the cords surrounding to that. So this is the typical arrangement of your cords in the costo-clavicular space. Axillary vein medially, artery immediately lateral to it, and the cords are arranged much more lateral to the first part of the axillary artery. And then everything should be done under sterile aseptic precautions before you go. And the patient is placed in supine position. You can do it, the needling can be either in plane or out of plane. I'm going to show the video of in plane. So this video shows the in plane approach of the costo-clavicular block. You can see the needle tip in that. Next video, I'll show the whole needle in that. Yeah, you can see the needle tip. I'm just hydrodissecting with the normal saline so that I get a clear space before I inject the local anesthetic. Here you can see the axillary vein more medially towards the marker, axillary artery in between the cords and the brachial plexus. And then you can see the needle tip slightly entering into that. Your aim should be the placement of the needle tip in between the plexus. Here, the lateral cord is situated more superficially, medial cord much more deeper, and the posterior cord much more lateral to the medial cord. Your prime aim is to deposit the local anesthetic into the cords, in between the three cords, lateral cord, medial cord, and the posterior cord. Okay, because the medial and the posterior cord are separated from the lateral cord by a septate. So you have to make sure that the needle tip is between the three cords. And then with the help of a normal saline, you can just hydrodissect and then enter into it, so that it can avoid nerve injury. See that just with the manipulating with the needle and then I'm hydrodissecting so that I don't inject into the cords. See, the lateral cord is separated from the other two cords, medial cord and the posterior. Finally, after injecting 20 ml, all these three cords will be completely separated and then soaked with the local anesthetic. Here you can see that the needle tip is at the center of all the three cords, and then they disperse in either direction. The lateral cord moves superficially, medial cord more medially and deeper, and posterior cord much more laterally. The ideal needle tip placement is between the three cords. Here you can see I'm just injecting over the lateral cord. Either it can be a 1-point injection or 2-point injection. The first point should be, you have to cross the septate and you have to inject in between the cords. to the medial and posterior cord, and second can be around the lateral cord. This is the 2-point injection, or you can do a single point injection at the center of the cords. $20 ml of local anesthetic will suffice. Here you can see after the injection of 20 ml of local anesthetic, the cords are separated from each other and they are fully soaked in the local anesthetic. You can see a small septate between the lateral cord and the medial and the posterior cord. You have to be aware of this. Otherwise, you can get some sparring. Vein more medially, first part of the axillary artery between the vein and the cords. Here the needle is introduced from lateral to the medial end. It's better to start from the lateral end towards the medial end, because towards medially the vein and artery are there. You can avoid the vascular puncture and injecting local anesthetic and hematoma. What are the potential complications? Vascular injury. If you are coming from medial to lateral end, you may obviously
Hello, Dr. Sendil, I think you got disconnected. We couldn't hear. And let's wait for Dr. Sendil. So this is what usually they do in Ganga Hospital. And all the possible blocks are usually done by them. Mostly all these cases are done under regional there. It is very fortunate for us to learn from the masters. And there is, I think, before Dr. Sendil joins back, I think one another patient teacher is there. Anyone wants to have a comment on that, on this topic, before Dr. Sendil joins back? Hello. All, can you hear? Can someone unmute and tell me whether you can hear me?
Yes, sir.
Yeah, I think Dr. Sendil got disconnected, and we'll wait for him to join back.
Jaykumar?
Yeah.
I am Dr. Sandu.
Yeah, sir. How are you?
Plus, your voice is clear, but your voice is clear.
Yes, sir. Yes, sir. I think he got disconnected. Dr. Sendil got disconnected, and we'll wait for him to join back. And if anyone has any experience on Costo-Clavicular block, they can share.
Actually, boss, in CMC.
Yes, sir. Yes, sir. Yes, sir. Tell me, sir.
Boss, in our hospital, CMC, I think one of our PG is doing this topic.
As a thesis.
Thesis, yeah. We are doing it
okay.
regularly.
Okay, okay. Okay.
I think it's I mean, as he told, it is a spine of upper limb now.
Okay.
Complications, single shot.
Yeah.
Useful. Definitely it will be useful.
Okay.
Is he joined?
No, he's yet to join. He'll join back. I think he got disconnected by internet. I think, as usual, the digital problem. And anyone wants to ask any question or this thing regarding the topic? Yeah, I think he's joining back. Yeah, Dr. Sendila, I think you got disconnected.
Okay, sir. At what time, sir? Sorry, I couldn't.
Yeah, the complications of the block when you started.
I'll come again, sir.
Yeah.
Sorry for the technical glitch. Sorry.
Yeah.
Complications. What are the potential complications?
No, we couldn't see the slides.
No, sir. I was started. No. Okay. So again.
It started, but got disconnected.
Okay, sir. I think some problem. Now are you able to see, sir?
Yeah. Can see the screen actually.
Okay.
Yeah. Okay, sir. Yeah, now we can see.
What are the potential complications? Complications would be to be the vascular injury if the needle is entered from medial to lateral direction, or it could be a nerve injury if you are without hydrodissection or hydroloxation, you just put in the needle into the cords. It could be local anesthetic systemic toxicity if you inject the whole of the local anesthetic into the vascular structures, and very rarely pneumothorax due to the pleural puncture if you go more deeper. Ideally, 20 ml of local anesthetic will suffice, either bupivacaine, levobupivacaine, or ropivacaine, with or without additive. What happens if you move from costo-clavicular space to the lateral infraclavicular space? The position of the cords changes. In costo-clavicular space, all the three cords are arranged more densely into the lateral half of the axillary artery. Well, once you move to the lateral infraclavicular space, they just rotate around and take the respective positions around the axillary artery. In costo-clavicular space, they lie lateral to the artery. Here, they lie all around the artery. Here, the lateral cord lies more superficially, posterior cord posteriorly, and medial cord lies between the axillary artery, second part of the axillary artery and the axillary vein. This is the sononatomy picture showing the lateral infraclavicular block. From superficial to deeper, skin, subcutaneous tissue, pectoralis major muscle, pectoralis minor, and the cords with the surrounding the axillary artery, second part of the axillary artery. This is a short video showing that when we move the probe from the costo-clavicular space to the infraclavicular space, how are the cords arranged around the artery. Here, initial picture, this is the costo-clavicular space, where the cords are arranged on the lateral side of the axillary artery. Once I move the probe from the costo-clavicular space to the infraclavicular area, the medial cord comes around the axillary artery and lies between the second part of the axillary artery and the vein. And the lateral cord lies superficially and lateral to the artery, and posterior cord much more deeper and posterior to the artery. This is the arrangement of cords in the classical infraclavicular area, where the lateral cord is arranged more superficially and lateral to the second part of the axillary artery. Posterior cord much more posterior and deeper, and medial cord can lie either between the artery and the vein. Thank you. This is a short presentation about the costo-clavicular block.
Thanks a lot, sir, for wonderful presentation. And I am one of the anesthetists who very rarely does any blocks, because I left this regional and general anesthesia for a long time. And it is actually more enlightening for me, actually. Actually, we are in a plan to do some of for the upper limb blocks, actually. This presentation has come in time for me, actually. So it is good. And what is the drug you routinely use? Either bupivacaine or ropivacaine?
We use both the drugs, sir. There's no both the drugs, 0.5% bupivacaine or 0.75% ropivacaine.
Okay. Which you consider better for surgical
safety-wise, ropivacaine is always better, sir.
Okay.
Safe. When compared to bupivacaine, ropivacaine is always safe. But when you take the volume and dose wise, you have to calculate the dose. But ropivacaine also you can use it until 3 milligram per kilogram. That's not an issue. And then ropivacaine gives you there is a slight delay when compared to onset of action, slight delay when compared to bupivacaine. But the duration of action is more with ropivacaine. It's like 1 or 2 hours more than bupivacaine.
Okay. Regarding sensory and motor, both are
almost equal. That's what the ropivacaine onset takes little time, sir. Ideally, in bupivacaine, you get within 5 to 7 minutes. But in ropivacaine, you have to wait until 10 minutes for complete blocking. That's the There's not much differentiation between the sensory and motor, like differential blocking, what you study, what you...
Okay, thank you, sir. And if anyone has any doubt about this costo-clavicular block, you can unmute and ask sir, so that he can clarify before we go on to anesthesia for scoliosis surgery.
Sir, I have one doubt, sir. I have one doubt.
Yeah.
Sir, what is the incidence of pneumothorax with this block, sir?
I have done almost more than 250, 300 blocks, sir. I haven't come across any pneumothorax, because it's very superficial, and then you should not go much beyond, sir. The needle tip should be always visualized. If you don't visualize the needle tip, and then if you go much more deeper, more than 4 centimeters, then you can have the chance of pleural puncture and pneumothorax.
More than 4 centimeters, you should not go. Okay.
Ideally, the cords will be located within around 3 centimeters.
Okay.
And then you can visualize with the ultrasound, you can visualize the needle.
Okay.
Thank you, sir.
Yeah. You use a longer needle or a shorter one? For
nerve stimulator needle will suffice.
15 centimeters. So, but that is a bit longer, and you should be very careful.
5 centimeters, 5 centimeter needle.
Yeah, 5 centimeters.
5 centimeters.
Yeah. Okay. So, any more questions? So, what are the surgeries you have done with this block, sir?
Almost the whole of the upper limb, right from proximal humerus to the shaft of humerus, elbow, both bone forearm.
Okay.
Everything.
Except the shoulder surgeries.
Yeah, shoulder also we can do, sir, with the supplementation of the superficial cervical plexus block. If needed, suprascapular. They say they have done studies also, sir. With costo-clavicular, the suprascapular nerve also gets blocked. So nowadays, with the high-risk patients, with obese patient, with pulmonary compromised patient, nowadays costo-clavicular is preferred over the interscalene also.
Yeah, actually, we are also thinking of putting the costo-clavicular block while we take radial artery harvesting. Of course, all the patients will be under general anesthesia, but the post-operative pain relief will be better this thing. And what's your experience on putting a catheter over this thing?
Absolutely. When compared to the supraclavicular or axillary catheter, this costo-clavicular catheter, putting in catheter is also very simple, and the catheter stands in the place because it's in between the muscular leg. The muscles holds the catheter in place. So the chances of dislodgement is very minimal with this.
So use a 2He needle to place.
2He, or you can use a Contiplex needle, sir.
Contiplex. Catheter. So what size needle or catheter you use for this thing?
20 and 19 got, sir.
20 and 19. Okay. So if no more questions, if anyone wants to ask any questions, you can unmute and ask. Otherwise, we'll go on for the next presentation. Yeah, well, if there is no question, yeah, someone is asking. Yeah, if there is no more questions, we'll go on to anesthesia for scoliosis surgery. Dr. Soumya, you can present the case.
Yes, sir, I'm sharing the screen, sir.
Yeah, sure.
Is it visible, sir?
Yeah, visible. Yeah. See.
So here is a 14-year-old female coming from.
Can you project it as this thing? Can you go for slide presentation? Yeah. Yeah, fine.
A 14-year-old female coming from Thrissur, Kerala, presented with complaints of deformity over the back, which was noticed 6 months ago and has come for further management. She was the first-born child born to the parents of non-consanguineous marriage. No significant antenatal or perinatal events. She was born by normal vaginal delivery, normal developmental milestones. She attained menarche 1.5 years back. There were no significant medical, surgical, or family history. No history of any cardiac or respiratory symptoms such as wheezing or coughing or any easy fatigability on exertion or while playing. No history of any pain in the leg, back, radiculopathy, or bowel and bladder disturbances. On examination, she's conscious, oriented, afebrile, moderately built and nourished, no pallor, icterus, clubbing, cyanosis, no lymphadenopathy, no pedal edema, no neurocutaneous markers. Her vitals, pulse was 96 per minute regular. Her blood pressure was 120 by 70 millimeter of mercury recorded in the right upper limb in supine position. Her respiratory rate was 16 per minute. Her saturation was, room air saturation was 99. And her height was 157 centimeters and weight is 48 kg. Her airway grading is Mallampati grade 2. Her mouth opening was adequate. She has no loose tooth. A systemic examination, the respiratory system on inspection, trachea appears to be on the midline. It was confirmed on palpation and percussion was normal. Auscultation, no added sounds, normal vesicular breath sounds were heard. On the cardiovascular examination, on inspection, no visible pulsation except for the apical impulse. On palpation, the apical impulse was present in the left fifth intercostal space, lateral to the midclavicular line. On auscultation, the first heart sound and second heart sounds were heard. No added sounds or any murmurs. Neurological examination, she's alert. No muscle weakness or no focal neurological deficit. This is a chest X-ray, which shows the curve to the right side, and this is her spine X-ray. Her blood investigations, the hemoglobin was 14.5 with hematocrit of 43.8%. Her WBC counts were 7,300, platelets 3,32,000. Her electrolytes and RFT were normal, blood group being B positive. Coagulation profile was normal, and ECG showed the normal sinus rhythm. A 2D echo showed the normal valves, chambers, good LV function, stable cardiac status, and also her PA pressures were also normal. The pulmonary function test revealed mild restrictive pattern. So she was diagnosed as adolescent idiopathic scoliosis. Considering the magnitude of the curve and progression, she has been planned for T2 to T12 posterior instrumented deformity correction and fusion. So to summarize, 14-year-old female with the complaints of back deformity with no significant medical surgical history, diagnosed adolescent idiopathic scoliosis, and has been planned for T2 to T12 posterior instrumented deformity correction and fusion.
Yes, sir. Do you want to continue the session and?
So shall we continue the session, or we can just have a question and answer like that? And then
we'll have a question and answer, so that like what they do in Viva and practicals, will do that. And okay. So that if any of the participants also has a question, they will either put it in the chat box or they can unmute and ask in the end of session.
Okay. I think Soumya, you can just continue with the anesthetic plan and then you can come back.
The anesthetic plan also I'll project, sir.
Yes, you can project it.
Okay, sir.
This was a real case that we did last week, sir. It was not cooked up or anything. This was a real case.
Yeah, it's fine actually.
So the anesthetic plan was general anesthesia with endotracheal intubation with the controlled ventilation with the total intravenous anesthesia with the target controlled infusion. So pre-op optimization, the patient was educated about the breathing exercises, including incentive spirometry. The previous night, tablet paracetamol 650 milligram per oral, tablet aceclofenac 100 milligram per oral, and alprazolam 0.25 milligram per oral, and pantoprazole with domperidone combination was given per oral. And so for solids, she was kept in NIT per oral for 6 hours and for clear liquids for 2 hours. So after the patient being shifted to the operating table, the monitors such as ECG, pulse probe, and non-invasive BP monitoring were attached. 2 wide bore IV cannulas were secured, and left radial artery cannulation was done for invasive blood pressure monitoring. So she was given injection glycopyrrolate 0.2 milligram IV, and injection propofol 150 milligram IV, injection fentanyl 200 microgram IV, and following induction, 10% lignocaine spray was sprayed over the vocal cords after laryngoscopy, and later intubated with the 6.5 mm ID cuff, the flexometallic tube, and it was secured after checking bilateral equal air entry. Post intubation, the temperature probe was placed in the nasopharynx. The ETCO2 was connected. She was catheterized. Ultrasound guided bilateral erectospinal block was given at 4 levels between T6 and T12 with 0.1% ropivacaine, 15 ml at each point. A total of 60 ml was given. Neuro monitoring was attached to monitor the evoked potentials. And the patient was carefully placed in the prone position. And again, the bilateral air entry was checked for the tube position. So she was maintained with the target control infusion with propofol at 3 to 5 microgram per ml, and air and oxygen 50% to 50%. Injection tranexamic acid 20 milligram per kg IV loading dose was followed by an infusion of 10 milligram per kg per hour. Injection dexmedetomidine 1 microgram per kg loading dose followed by between 0.2 and 0.4 microgram per kg per hour was maintained. She was given antibiotics, 1.5 gram of injection cefuroxime and injection piperacillin and tazobactam 4.5 grams. Antiemetics injection ramosetron 0.3 milligram. Injection paracetamol 700 milligram. Injection ketorolac 30 milligram. Injection dexamethasone 8 milligram. Injection pantoprazole 40 milligram. And ketamine 30 milligram and morphine 5 milligram was given. Hypertension was maintained during the exposure, and MAP was maintained throughout more than 60 mm of mercury. The surgery lasted for 4 hours 15 minutes. A total blood loss was around 800 ml. The urine output was 400 ml over the period of 4 hours and 15 minutes. Normothermia was maintained throughout the procedure. She was given 1.5 liters of pistolites totally and 1 hydroxyethyl starch, and 2 units of Paxil were transfused. The child was stable throughout the intraoperative period and was later shifted to the high definition unit. And after 3 to 4 hours of elective ventilation, she was extubated, while dexmedetomidine infusion was also continued.
Okay. Soumya,
sir,
you can just stay with the presentation, and then you can just explain to them what is a scoliosis, and then what is the classification, how it is classified, different types.
Okay, sir. The spine normally curves posteriorly in the thoracic region and anteriorly in the lumbar region. So the physiological curves are the thoracic kyphosis and the lumbar lordosis. Scoliosis, I'll share the presentation.
Yeah, you can share.
Okay, sir. So the scoliosis refers to lateral curvature of the spine. In addition to the lateral curvature of the spine, the vertebrae can also be rotated, and the rib cage may be markedly deformed. So etiological classification of scoliosis include 70% it is idiopathic, with the early onset, which is infantile, and late onset, either juvenile or adolescent. The neuromuscular classification includes those with the cerebral palsy, myopathies, poliomyelitis, syringomyelia, Friedreich's ataxia, and congenital causes include vertebral anomalies and rib anomalies. Traumatic causes include vertebral fractures, radiation, and following surgeries. The syndromes associated with scoliosis include Marfan's, rheumatoid arthritis, osteogenesis imperfecta, mucopolysaccharide disorders, neurofibromatosis, and neoplastic causes include primary and secondary tumors, and infective causes include tuberculosis and osteomyelitis.
Okay. What is corpse angle? How will you calculate the corpse angle? And what is the significance of corpse angle with the respiratory physiology and the morbidity and mortality of the scoliosis? Could you just explain, Soumya,
Yes,
with the presentation?
Yes, sir. With the presentation, sir?
Yeah, with the presentation. You can continue with the presentation. So that it will be easy for the delegates to see and visualize and understand.
So to measure the severity of scoliosis, commonly we use the Cobb's angle. The Cobb's angle is measured on a spine radiograph. To use the Cobb's method for measuring the degree of scoliosis, choose the tilted vertebrae above and below the apex of the curve. First locate the curve, apex of the curve, and see the most tilted vertebrae above and below. The angle between the intersecting lines drawn perpendicular to the top of the upper vertebrae and the bottom of the lower vertebrae forms the Cobb's angle. The more severe the thoracic curve, the more profound the disturbance in pulmonary function. So surgical treatment is usually recommended for curves greater than 45 to 50 degrees. Curves greater than 60 degrees are usually associated with decrease in pulmonary function. So scoliosis severity and impairment of pulmonary function also increase with the number of vertebrae involved if it is more cephalate and with the loss of normal thoracic kyphosis. So what is the significance of knowing the degree of Cobb's angle? So if it is less than 10, it is usually a normal curvature. When it is more than 25, there is echocardiographic evidence of increased pulmonary artery pressures. When it is more than 40 or 45 to 50, surgical intervention is needed. And when it is more than 65, usually the patient will have definite restrictive lung disease, and more than 100, symptomatic lung disease, dyspnea on exertion, and increased risk of death from cor pulmonale and right ventricular failure. When it is more than 120, their alveolar hypoventilation occurs. So how does scoliosis affect the respiratory system? Lung volumes and pulmonary compliances are inversely related to the degree of the curvature. So usually the FEV1 and FVC is normal, but there is decreased vital capacity due to the inspiratory muscle weakness, because of the mechanical disadvantage of the respiratory muscles. The total lung capacity is also decreased because of the decreased lung compliance. The functional residual capacity is decreased, and relatively residual volume is preserved. Alterations in the lung volumes are caused by changes in the chest wall compliance and the resting position of the thoracic cage rather than the parenchymal changes.
What are the cardiovascular changes? What are the cardiovascular complications or congenital? Anything cardiovascular changes, any chamber abnormality or any other thing what you have to look when you assess a case of scoliosis, Soumya?
Yes, sir. So right from the history itself, when we are collecting the history, it is important to assess the cardiopulmonary reserve of the patient. This can be easily asked if it is by asking the patient whether they usually get tired or whether they are able to cope up with while playing with their friends or not. If they are not getting tired or not getting exhausted, usually the cardiopulmonary reserve is good. And 25% of the patients with scoliosis have mitral valve prolapse. And if it is associated with the syndromes like Marfan's, aortic regurgitation can also be present. And because of the hypoxia, the pulmonary vasoconstriction occurs and the pulmonary vascular resistance increases, and this can end up in increased pulmonary arterial pressure.
Okay.
And it can also result in right ventricular hypertrophy and right ventricular failure.
Okay. If you got a case of a scoliosis, how are you going to evaluate the patient and how are you going to optimize the patient before posting her for surgery? How are you going to do that?
So it is before optimization, it is important to know the location of the curve, the age of onset, the severity, the direction of the curve, and etiology of scoliosis. So the location of the curve, when it is thoracic, the pulmonary function is abnormal. And when it is cervical, we have to have a caution that there is going to be difficulty in airway management. So the age of onset, the lung continues to grow from till the age of 8 years, as the number of alveoli also keeps on increasing. Around almost from 25 million, it increases up to 250 million. So the development of significant thoracic scoliosis during this phase of rapid growth impairs the lung development, causing a significant reduction in the alveolar number in early onset. So the severity, depending upon the corpse angle, more than 60 degrees, there is significant reduction in the pulmonary function. And when the angle is more than 100, there is significant impairment in gas exchange as well. So the direction of the curve is also important. More commonly, the direction of the curve is towards the right. But when the patient has a left thoracic convexity, always looking for other congenital anomalies. So the etiology of scoliosis is also important, as when is associated with neuromuscular disorders like muscular dystrophy or cerebral palsy. The patient will have more compromised pulmonary function, and also it is important to educate the patient and the attender about the post-op need for post-op ventilation. And also there are studies that patients with the neuromuscular disorders, there are increased bleeding during the procedure.
Any special history that you have to elicit from the patient out of the investigations, and how will you prepare the patient?
So as earlier I mentioned, when talking about the cardiovascular system, the cardiopulmonary function should be assessed, inquiring about the patient's exercise tolerance mainly. So in general, if the patient is able to keep up with the friends in vigorous activity, will have a good cardiopulmonary function. Pulmonary symptoms such as episodes of wheezing or cough may indicate parenchymal or a reactive lung disease and alter the perioperative management. Patient with the muscular dystrophy, Marfan syndrome, and neurofibromatosis should be questioned about symptoms suggestive of cardiac conduction abnormalities such as palpitation or syncope.
What are the pre-op investigations that you will be doing before taking up a case?
Pre-op investigations include right from assessing the airway and assessing the patient for positioning, any history of if the patient has any respiratory tract infection, a complete blood count, coagulation profile, the pulmonary function test, 2D echo, electrolyte and renal function test, X-ray, ECG, the blood grouping, and height and weight.
Can you elaborate about PFT and bedside pulmonary function test? What are the abnormalities that you can expect in PFT?
Okay, sir. Usually the pulmonary function test will show a restrictive pattern with decrease in the lung volume, which is most common in thoracic scoliosis. There is greatest reduction in the vital capacity, which is typically reduced to 60 to 80% of the predicted value. The total lung capacity, the functional residual capacity, inspiratory capacity, and expiratory reserve volume are also decreased. We can also do bedside pulmonary test like cough test, wheezing test, or breath holding test, or single breath count can also be done.
Any other investigations you want to do, or anything, any abnormality you can get from other investigations?
So in ECG, usually if the patient has developed right ventricular hypertrophy or a right atrial enlargement, it can be seen. And if the patient has other evidence has ECG changes, we can go for electrocardiogram, particularly if the patient has pulmonary hypertension, to know the pulmonary arterial hypertension pressures.
Okay. Any other neurological assessment or anything? You know?
So the respiratory system and cardiovascular system are definitely should be examined, while also pre-op neurological assessment is very important, as because usually the patients with the pre-existing neurological deficits are at increased risk of developing spinal cord injury during scoliosis surgery. So it is very important to document the preoperative neurological function in order to avoid confusion about postoperative neurological complications.
Okay, I got a question from the delegate. Why not ABG in place of a PFT? PFT, in case if you have severe abnormality in the PFT, if you have severe restriction, then you can do a baseline ABG as soon as you put in an arterial line. And then you can see the oxygenation, any defects in oxygenation or anything like that. Okay, how are you going to prepare the patient? How are you going to counsel the patient? How are you going to prepare the patient? Or if you need any special preparation for this surgery?
Yes, sir. The patient in the preoperative period should be well educated about the breathing exercises and incentive spirometry, as this is also important in initially optimizing the pulmonary factor, and also in the post-operative period. Only when the patient has been educated in the preoperative period about the breathing exercises and the incentive spirometry, the patient will be able to do it in the post-operative period, which is even more important. If there is any respiratory infection, it should be treated, and it is important to build up the hemoglobin. It can be given either by oral iron, and to induce erythropoiesis, erythropoietin injection can be given. And if the patient is, if we are going to plan for any autologous donation prior to the procedure, the erythropoietin injection should be given, which increases erythropoiesis, and it will later help in doing autologous transfusion as well. So in preoperative counseling, we should counsel the patient that the surgery is going to be for a long duration, and there's going to be increased blood loss, and the patient may be requiring invasive cardiovascular monitoring, and the chances of developing new neurological deficits and the neurophysiological monitoring which will be required. And if we are going to have a wake-up test during the intraoperative period, it should be well explained to the patient. And the post-operative analgesic regimens should be explained to the patient, as the patient can require maybe put on IV patient control analgesia, or in epidural insertion can be needed. And most importantly, if the patient has neuromuscular deficits or neuromuscular diseases, the patient should be educated about earlier should be primed about the post-op ventilatory requirements. And also, when the FVC is less than 50%, the post-op mechanical ventilation should be explained to the patient.
What are the monitoring that you need? Do you need any special monitoring for this as a major case?
The intraoperative monitoring, apart from the ECG, continuous invasive blood pressure monitoring, the ETCO2, the pulse oximetry, and urine output and core temperature, we need neurological monitoring, and an independent personnel should be required for this.
Then we also need a BIS monitor.
A BIS monitor.
Okay. Could you just go through about the conduct of anesthesia? How are you going to pre-medicate, induce?
Okay, sir. So the patient is usually pre-medicated with the antisyllagogues, and antiemetics should also be given. And the primary concern is the ability to provide suitable anesthesia for spinal cord monitoring. So usually a low dose potent agent like isoflurane can be used with 50% oxygen and air mixture with low dose propofol infusion, and primarily opioid based intravenous anesthetic technique is used. But now many of us use total intravenous anesthesia, and with the TCI it can be used, where we only use the inhalation agent is also not required, and dexmedetomidine has been used as an adjunct to the total intravenous anesthesia with minimal effects on the evoked potentials, motor and somatosensory. So preferably it is TIBA with the TCI, which we are doing in our institute, and it is advantageous for the neuromonitoring.
I got a question from the delegate. Is muscle relaxant totally need to be avoided in these type of cases? I'll answer my question in two parts. First, yes, it's better to avoid because in case if you are doing a neuromuscular scoliosis, there is always going to be a delay in muscle relaxant coming out. Second is that in our institute, we start the neuromonitoring right from the induction. So muscle relaxant can hinder the neuromonitoring. That's the second point. Okay. Next, Soumya, could you explain about the total intravenous anesthesia and how you do the total intravenous anesthesia?
Yes. So the target controlled infusion is an infusion controlled in such a manner as to attempt to achieve a user-defined drug concentration in a body compartment of interest or tissue of interest. The target concentrations are calculated and they are not usually measured. The TCI pumps maintain 3 superimposed infusions, 1 at a constant rate to replace the drug elimination, and 2 exponentially decreasing infusions to match the drug removed from the central compartments to the peripheral compartments of distribution. So the adequacy of TIVA will depend upon the maintenance of, in this case, maintenance of brain propofol, which are clinically appropriate and in equilibrium with the levels in the plasma. The best way to achieve this state is by target controlled infusion from dedicated pharmacokinetic pumps. These devices solve the complex equations which describe the distribution of agents between the compartments and allow for rapid adjustments in targets to achieve the desired clinical effect. Manual infusion regimens are prone for errors in calculation, and therefore it is better to use a TCI pump. So word about the 3-compartment model. So when after an IV bolus, the plasma concentration of a typical drug follows an exponential decline in 3 distinct phases. These observations are explained by distribution of the drug between a central compartment, V1 principally the plasma, and 2 compartments which equilibrate either rapidly or slowly. Rapidly, the V2, usually the well-perfused tissues like muscle, and slowly, usually the slowly perfused, usually the less perfused the tissues like fatty tissue. So mathematical analysis allows the compartment volumes and rate constants for drug transfer between them to be calculated. So the principles of the TCI is that a bolus, elimination, and transfer principle is used to approximate a constant plasma level of drug. So once the compartment B1, which is the central compartment, is filled by the bolus, the subsequent infusion rate compensates for rapid and slow transfer of drug to B2 and B3 respectively, and drug elimination from B1 as described by rate constant K10. So this is the TCI pump which we use in our institute. So the TCI, the key components are user interface. It has a microprocessor with pharmacokinetic software, an infusion pump which delivers up to 1200 ml per hour, and visual and audible safety systems and alarms. So a typical system calculates the bolus and the speed of subsequent infusion required to maintain the targeted plasma drug concentration. The calculations are repeated every 10 seconds and the infusion rate adjusted until the targeted plasma drug concentration is achieved. So diffusion of drug from plasma to brain occurs exponentially with the first order rate kinetics, and the half time for this process is calculated by as T half, and the equilibrium occurs after 4 to 5 half times. The targeted plasma drug concentration is to be subsequently, if it is to be subsequently increased, an additional bolus is given to fill the central compartment, which is V1, and the infusion rate increases to match the additional transfer and elimination at the higher concentration. When the CPT is to be decreased, the infusion stops until the plasma concentration declines to the new target, and it is restarted at a lower rate. So the diffusion of drug from the brain occurs with the same half time. So there are various models for TCI pumps. The Kataria and the pedofusor model is used for pediatric age group. While the Marsh model is used for adults. Just to explain about the Marsh model, in this diagram explains the plasma and the effector site during a TCI of propofol. The initial target concentration is set at 3 microgram per ml. Then after 5 minutes, the target concentration is altered to 6 microgram per ml. And at 10 minutes, the target concentration is again set back to 3 microgram per ml. It can be seen to achieve that the target plasma concentration, the green line, the infusion rate constantly keeps changing. So an initial bolus dose achieves a plasma concentration of 3 micrograms per ml, and the infusion rate is maintained at a steady level. So at 5 minutes, in order to achieve a target plasma concentration of 6 microgram per ml, a bolus dose is again delivered, and the infusion changes to a new steady infusion rate.
Okay. This TCA model, this pharmacokinetics, all academic part will be more elaborate. You have to understand that. But once the using a TCA pump is very easy. Okay, just you have to set in what is the height of the patient, weight of the patient, and then you have to set what concentration you need. What is the plasma concentration you need? Once you set that, the machine will automatically deliver how much of ml of the volume. How it delivers is that they have studied n number of patients. If this volume is infused into the patient, that will achieve the plasma concentration. That has been studied, and then it is set into the software. You have to just enter the concentration, and this concentration initially you need a higher concentration, and gradually you can reduce the concentration in relation to the BIS monitor. BIS will always help you. Without BIS, it's very difficult to use this TCI pumps. Hope all the delegates are understood about this. What are the concerns of this amount of major surgery, Soumya? What are the major concerns? Intraoperatively, what are the concerns that you have? And how are you going to tackle?
So the major intraoperative concerns include right from the positioning, the prone positioning, and the amount of major blood loss that can happen, and the transfusion related complications. So in prone position, the cardiovascular changes, our main concern is that it is going to increase the intrathoracic pressure, which is going to decrease the venous return and decrease the stroke volume. Thereby, the cardiac output is decreased. The venous congestion of the spinal and epidural vessels occur. And this again can result in increased bleeding as well. And if the patient is not placed in a proper prone position, the IVC compression can occur. But in the respiratory system wise, the FRC and the partial pressure of oxygen, it is actually more better for the patient in a prone position, except when the abdomen is not placed properly, or when it is compressed, the airway pressures increase. And while it is the intraocular pressure increases in a prone position. So this is in a way the patient should be placed properly in a prone position with the minimal flexion of the head, the shoulder with the small degree of anterior flexion, abducted and externally rotated to less than 90 degrees. The abdomen should be free. There should be no pressure on the axilla, and the elbow should be padded, and the face is placed in a soft head ring with no pressure on the eyes or the nose. So the problems associated with prone positioning, right from the airway, there can be the endotracheal tube kinking can happen, or dislodgement can occur. The upper airway edema can occur, and the airway pressure can increase. So when the neck is not placed properly, or it is hyperextended or hyperflexion, there could be the compromise on the venous drainage of the brain. So the eye, when compression on the eyes is present, the intraocular pressure increases, and supraorbital nerve compression can occur. Even corneal abrasions can happen. When the abdomen is much compressed, epidural vein congestion can happen, and the airway pressures can also increase. When the arm is not kept, upper limb is not kept properly, brachial plexus injury can occur, ulnar nerve compression can occur, and in the lower limbs, when the flexion of hip can occlude the femoral vein, and the pressure on the pressure lateral to the fibula can compress on the peroneal nerve, and also pressure on the anterior superior iliac spine can cause pressure to the lateral femoral cutaneous nerve.
Actually, we use a sponge, soft sponge with a mirror underneath it, so that you can visualize the eyes, nose, and everything. And then it's always better to use a flexometallic tube. And then as soon as you turn to prone position, always check for the airway pressure and the hemodynamics. Okay. Good.
So the next major concern is blood loss. It depends upon the levels of correction, the duration of the procedure, the stages of the surgery, the bone mineral density, the type of the disease, and when dissecting the vertebrae, when the screw is being placed, when the rod rotation or distraction happens, and when bone grafting has been done. So the strategies to minimize the blood loss starts in the preoperative period, as well as we already earlier saw, optimizing the hemoglobin. So we should prepare the patient, and we should estimate the blood volume, anticipate the blood loss, and so that we can notify the blood bank, and timely assessment of ongoing loss should be done. Throughout the procedure, normothermia should be maintained. The maintenance fluid should be transfused, given, replacement by colloids and blood products, and intraoperative hemoglobin, ABG, and coagulation should be done. So even with the positioning, if the abdomen is going to be compressed, it is going to cause the spinal and the epidural vein engorgement, causing increased bleeding. Surgical hemostasis is essential. Adequate analgesia and induced hypotension can be done during exposure, but deliberate hypotension even throughout the procedure is not recommended, as it can cause spinal the cord ischemia. The pharmacological agents like tranexamic acid and aprotinin can be used. And word about the autologous transfusion. So it is the collection of blood from a single patient and retransfusion back to the patient when required. There are cell salvage, preoperative autologous donation, acute normovolemic hemodilution. So the cell salvage, this is the cell saver machine which we have in our institute. The blood is collected from suction, surgical drains or both, and retransfused back to the patient after filtration or washing. So acute normovolemic hemodilution, the patient with normal hemoglobin following induction of anesthesia, through large IV cannula, 15 to 20 ml per kg blood is withdrawn. The blood volume is restored with crystalloids, and later this collected blood is transfused to the patient either during the end of the procedure or when there is going to be blood loss. A preoperative autologous donation is done when the patient should have a hemoglobin of at least 11 grams. Subcutaneous erythropoietin of 400 units per kilogram induces erythropoiesis given 4 weeks prior to the scheduled date. So following that, the blood is collected every 4 to 7 days, starting 2 weeks before the surgery, and the last collection should be at least stopped at least 72 hours, that is 3 days before the surgery, and around 450 ml is withdrawn each time, can be withdrawn each time, and up to 4 units can be taken. So the transfusion can also cause complications. Transfusion related acute lung injury can happen. This is a non-cardiogenic pulmonary edema associated with hypoxia that occurs during or after transfusion. So the immediate management of TRALI is to stop the infusion, and we can notify the blood bank if it is going to be, if it is not an autologous transfusion. And supportive measures must be taken to improve oxygenation. Although there is no specific treatment for TRALI, since it is similar to ARDS, we can use a low tidal volume ventilation for TRALI.
Let me just explain in simple ways about this cell salvage machine, blood salvage. It's actually a suction. It sucks in blood and keeps in the suction bottle-like thing. It's a disposable membrane filter, where after the end of the surgery, it washes away RBCs, or it keeps in the RBCs and washes away other cell debris, WBCs and everything. And then it is put in a centrifuge machine so that the RBCs alone is collected. And then the collected blood will contain only RBCs with oxygen-rich blood. So it can be transfused to the patient immediately. And then here in our institute, we use tranexamic acid as the pharmacological agent. We use a high-dose tranexamic acid. Initial bolus dose is about 20 milligram per kilogram. And then infusion, we give dose range between 5 to 10 milligram per kilogram per hour. This is a high-dose tranexamic acid infusion, which is mainly used in spine surgeries to prevent excessive blood loss. Next, Soumya, could you just elaborate about the neurological monitoring, neuromonitoring, how they do, yes, and what are the things they do?
So the neurological monitoring, the two monitoring techniques most commonly used to monitor the spinal cord function during scoliosis surgery are the somatosensory evoked potential and the motor evoked potentials. The somatosensory evoked potential, the sensory information from the periphery passes through the posterior column of the spinal cord on its way to the cerebral cortex. This technique involves applying repeated electrical stimuli to a peripheral nerve, example the posterior tibial nerve, and measuring the evoked response over the cerebral cortex and subcortical regions using standard EEG scalp electrodes. So an increase in the latency or decrease in the amplitude or a complete loss of the evoked potential should be considered indicative of a surgical injury or ischemia until proved otherwise. The MEP is used to assess the integrity of the spinal motor pathways, the anterior column, while somatosensory is for the posterior column, while motor evoked potential is for the assessing the anterior columns. The motor evoked potentials are elicited by transcranial electrical stimulation of the motor cortex using scalp electrodes or by stimulation of the anterior columns using epidural electrodes as well. The conduction of these stimuli through the motor pathways is monitored as peripheral impulses and the electromyographic signals or axial limb movements. So this is the picture of the somatosensory or evoked potential monitoring which we do in our institute. This is the video. So what are the factors that can influence these evoked potentials? So the volatile agents decrease both the amplitude and latency. Nitrous oxide decreases the amplitude, while propofol has not much effect. Ketamine has increases the amplitude and it has not much effect on the latency, while midazolam decreases the amplitude. Opioids do not have much effect. Relaxants, although it can be, they do not directly influence the evoked potentials, but it can influence the motor evaluation while during MET.
Yeah, that's why we don't use relaxants, because very minimally they can impact, and that could not be a factor to just deteriorate. And then volatile anesthetics also, we usually avoid volatile anesthetic. One, because of this factor, because they can involve into they can decrease the amplitude. Another is that the patients with neuromuscular scoliosis, they have a chance of going into complication of malignant hypothermia syndrome. So there is always a chance. So we better avoid volatile anesthetics also. Okay. Next, in case, Soumya, if you are not having a neuro monitoring and everything, how are you going to assess the neurological function in between the surgery?
It can be done by wake-up test. The wake-up test is used to assess the integrity of the spinal motor pathways and is performed by lightening the depth of anesthesia sufficiently to allow the patient to follow commands. This is usually done as soon as all the instrumentation is in place, or if we notice any abnormality in the spinal cord monitoring. So the patient is first instructed to squeeze the anesthetist's hand, confirming that he or she is responsive, then is asked to move his or her feet or toes. If the patient is able to squeeze the hands but unable to move the feet, the amount of spine distraction must be reduced until a safe degree of correction is achieved. So when the patient starts moving the feet, the anesthesia is quickly deepened with small doses of propofol, and additionally benzodiazepines can be given. The recall of this event is usually does not happen, but wake-up test also comes with there are complications associated with by doing a wake-up test. So extubation in the prone position can occur, and a recall of the intraoperative events can happen. Myocardial ischemia can occur, self-injury, dislodgement of the instrumentation or the IV access. Air embolus from the open venous sinuses may occur if the patient is breathing spontaneously and inhales vigorously.
Yeah, that's one of the important topic. Any chance of venous air embolism?
Yes, venous air embolism is a very rare during spine surgery, but it is, if it happens, it is a very catastrophic event. Large amount of bone is exposed, and the elevated location of the surgical incision relative to the heart predisposes to venous air embolism. Air is more likely to be entrained from the open epidural and the paravertebral veins and venous sinuses in decorticated bone. So when there is sudden hypotension with fall in EtCO2, always suspect venous air embolism. So when this happens, the surgical field should be immediately flooded with saline. Ventilation should be begun with 100% oxygen, and intravascular fluid administered should be increased to increase the central venous pressure. Flooding the field with saline prevents further air entrainment, and ventilation with 100% oxygen reduces the volume of the air embolus, particularly if nitrous was administered. So hypovolemia and low central venous pressure will favor further air entrainment by increasing the pressure gradient between the open veins and the right atrium. Therefore, it is important to administer intravascular fluid should be administered to increase the central venous pressure.
Okay. What are your plans? How are you going to extubate the patient on table or elective ventilation after a while? How do you categorize and how will you arrive at a conclusion? And what will be the pain management, intraoperative and postoperative pain management? What are the various options you have, Soumya?
So our main in the postoperative period, whether to extubate the patient or not, and the pain management, and above all, it is also the pulmonary the respiratory system should be optimized well even in the postoperative period. So the extubation, coming to extubation, it can be either patient factors or surgical factors. When the patient has severe restrictive lung disease, and or when the vital capacity is less than 35%, or when the patient has associated neuromuscular disease, or when the patient is very obese, it is better to go for mechanical ventilation. And coming to the surgical factors, when the if it is going to be a prolonged surgery, when multiple levels of correction is done, it is better to go for post-op ventilation.
Okay, in our institute, almost 90% of the patients we extubate on table. Almost 5 to 10% we leave them for a little elective ventilation for 3 to 6 hours, and then we extubate. What will be the pain management? What is the analgesia? What are the various options?
So the pain management, usually it is multimodal analgesia to optimize the postoperative pain control in pediatric patients, especially undergoing posterior spinal fusion, including a simple analgesic, systemic opioids, and even regional anesthetic techniques. Patients with the idiopathic scoliosis are typically developmentally mature enough, can even use the intravenous patient controlled analgesia. An epidural catheter can be placed intraoperatively by the surgeon. And after initial neurological assessment, a loading dose of the local anesthetic is then given, followed by continuous infusion. Opioids can be administered intravenously, intrathecally, or via the epidural space. So epidural analgesia, this can be done by asking the surgeon to place the epidural catheter before closing the ligamentum flavum. Either it can, a single catheter can be placed, or two-level catheter, one at the high thoracic and the other at the lumbar region can be placed. So now in our institute, we give erector spinae block, which is very useful for the patient, especially it helps in the early mobilization of the patient, and the patient almost remains pain-free for almost 1.5 days or so. The erector spinae block is the most often performed using an in-plane ultrasound guided technique. It is a paraspinal facial pain block in which the needle placement is between the erector spinae muscle and the thoracic transverse process, and a local anesthetic is administered, blocking the dorsal and the ventral rami of the thoracic and the abdominal spinal nerves. This blockage of the dorsal and the ventral rami of the spinal nerves helps to achieve a multi-dermatomal sensory block to the anterior, posterior, and the lateral thoracic and abdominal walls. It provides excellent analgesia in the postoperative periods, and it also helps the patient to be mobilized earlier. So this is the picture where showing the erector spinae block. So in the
next question is that how are you going to manage hypothermia? What are the steps you take to keep the patient in normothermia?
So we can transfuse the patient with the warm fluids and irrigation. The surgical field can be irrigated with the warm saline, and warm blankets can be used to maintain the normothermia, sir.
Okay. What are the complications that you expect during intraoperatively and postoperatively?
The complications following the surgery include wound infection, the pulmonary complication, and even neurological injury. When anterior spine fusion is done, there are increased risk of pulmonary complication. Almost 100% of the patients undergoing these procedures will develop atelectasis. So incentive spirometry and deep breathing exercise should be emphasized. Pulmonary complications that have been reported in the postoperative period include pneumothorax, atelectasis, pleural effusion, hemothorax, and thoracic duct injury. Atelectasis may occur because of prolonged supine positioning and even by use of opioids.
Okay. What is any recent advances or recent techniques, or what is ERAS says for scoliosis?
So prior to the surgeries, these patients should be, the investigation should be done, and we should avoid prolonged fasting. So carbohydrate rich beverage in the morning of the surgery can be given, and autologous blood transfusion, autologous blood in the weeks leading to the surgery to avoid any allogenic transfusion can be done. It is very important to educate the patient about the incentive spirometry, and also if you are going to go for a wake-up test, it should be well explained to the patient in the pre-op visit. Intraoperatively, the posterior spinal fusion pathways will focus on initiating multimodal analgesic therapies, preventing any neurological complications associated with the operation and positioning, and decreasing the perioperative blood loss and the need for any allogenic blood transfusion with by using antifibrinolytic therapy and also using cell salvage. The postoperative course should be structured early recovery and rehabilitation, and the patient should ideally return to the normal function quickly.
Okay, okay. Could you just summarize, Soumya, about the whole thing?
So managing a patient for scoliosis surgery, it starts from the preoperative period, right from when the patient is scheduled for the surgery. It starts even weeks before surgery, while right from optimizing the hemoglobin and assessing the level of deformity, proper counseling of the patient, and pulmonary optimization. And the blood conservation strategy should be explained to the patient, and we should be well prepared for that. And adequate pain relief in the post-operative period is very important, which helps in early mobilization. And the post-operative incentive spirometry is very important and should be educated prior in the pre-operative period, so that the patient will need it even in the post-operative period, should be encouraged about it. Most of our patients will in the post-operative period, they don't do that. So they should be explained priorly about the incentive spirometry.
Post-op pain management is a very important thing that you have to do because it helps in early mobilization. What we do in our institute is that we start with intravenous infusion of either fentanyl or morphine. On top of it, it's a multimodal analgesia with the paracetamol and an NSAID like ketorolac. And we also just a patch with an insert a patch, buprenorphine patch. It's really about 5 milligram patch for young children. That helps a lot to achieve the acute and chronic pain relief. And then I got some questions in that. Rhabdomyolysis, how common it is? We don't see rhabdomyolysis at all. It's usually seen in polytrauma patients, not in scoliosis correction or anything. And then how much of hypotension? That's what. It's not a deliberate hypotension. It's the hypotension to prevent blood loss during exposure of the scoliosis surgery, not during instrumentation or correction. During instrumentation or correction, you have to maintain a higher MAP so that you can prevent the spinal cord ischemia. It's hypotension in between around 60 to 65 MAP during exposure will bring down your blood loss. How common is air embolism? Air embolism is also very rare. We haven't encountered anything. And regarding TRALI and transfusion-associated circulatory overload, I think Dr. Vijaykumar sir is a better person to explain that because is the right person.
TRALI is usually a non-cardiogenic, and TACO is, as name suggests, it is because of the positive fluid balance and because of cardiogenic involvement. And to make it as a TRALI, it is because of so many markers increase because of the multiple transfusion. And before marking, we should ascertain that there is no fluid overload. Particularly, the left atrial hypertension should not be there. That is the main cause for TACO. So you have to rule out positive fluid balance and cardiogenic involvement. That is about TACO and TRALI. And about deliberate hypotension, I think we can allow, if it is a prolonged surgery, we can allow. But how long is a question? But usually what we do is we maintain hypotension till we get at least 0.5 ml per kg of urine output. That is the MAP we allow to fall. It is different between each patient because some patients has a higher blood pressure and their mean arterial pressure is usually higher. So we can't fix the mean arterial pressure as 60 or 50, 60 or 70 for all patients. So usually there should be criteria-based hypotension. So what we do is we titrate till we get a good urine output of a minimum 0.5 ml per kg per hour. That is the cutoff limit for the mean arterial pressure. If we, when there is a fall in urine output, then we tend to have a little, increase the blood pressure a little higher. That's what we do. Ultimately, we should not end up with renal dysfunction. So any more questions? Anyone want to ask? It's a nice presentation, and almost it has covered entire spectrum of scoliosis, and it is a wonderfully prepared session. And because scoliosis surgery is frequently asked in the theory aspects, and practically also there is a lot of points to be discussed. Particularly, they have discussed about autologous transfusion and intraoperative hypertension, then evoked potential, and so on, which not many centers do on regular basis. Of course, there are centers like where they do cardiac surgeries, they do cell savers and so on, but not much centers they do cell savers. But definitely in practical exam, they might end up with some questions about that. That's what. And what else? Anyone wants to add up or question anything? And about the transfusion trigger level, the American Association of Blood Bank guideline in 2016 is set as 8 gram percentage as a transfusion cutoff. And as such, it is not a cutoff for all patients. It there are so many factors involved where if a patient has any coronary artery or renal dysfunction, we can have a higher cutoff for transfusion. And that's it. If anyone wants to have anything.
I just wanted to add up a point, sir.
Yes.
In scoliosis, there might be little pulmonary compromise. So we usually have a target of high hemoglobin of more than 10. That's the protocol we follow. Yeah.
Even in cardiac surgery, though it has been set as 8, we usually follow 10, as you told. 10 is our transfusion cutoff. So if it falls below 10, we tend to transfuse, and particularly about hemodynamics also. And but few patients we tend to have a little lower hemoglobin on subject basis. That is one. So next class we'll be having renal dysfunction CKD patient coming for non-renal surgeries. That is the next class. And Dr. Prabha or Dr. Muthukumar will be joining me for the discussion. And Dr. Anbumani is a postgraduate who will be presenting the case. So it's a nice session, sir. Thanks a lot. Almost spending 1.5 hours. It is very educative. Actually, this is a low looked upon topic, actually, which is very important, both in the practical as well as in the Viva session. It is actually all the points for Viva has been touched upon and covered and clearly explained. And I have to congratulate Dr. Soumya also. She has prepared well and has communicated very well and to all the postgraduates who have attended this session. And thanks a lot, Dr. Sindhil and Dr. Soumya.
Thank you, sir.
Thank you.
Thank you. Well done, sir.
Thank you.
Yeah. Thank you. We'll end up and we'll meet next week for the CKD patient for non-renal surgeries. Thank you. Good night.